Hello friends, this is a case of giant inguinal hernia on the right side of a 38-year-old male, and we are performing the Da Vinci robotic hernia surgery, and there is a lot of content in the right inguinal hernia. This is an indirect inguinal hernia, but thankfully all the contents are omentum. So the first step is just to take all the content out, because without removing the content of the sac you cannot perform the hernia surgery. So first step should be complete removal. Here entire surgery we have done by the one atraumatic grasper on the left side, and right hand we have the this micro needle holder. So ideally the removal of the content should be better with the two atraumatic bowel grasper. That is better to remove the content, because bowel grasper jaws are very long and they are less traumatic to the bowel or omentum. But again, for the cost constraint we cannot use the multiple instrument in robotics. So right side, instead of grasper we have the needle holder, and the left side is a atraumatic grasper. And the first step of the surgery is that to remove all the content. This is irreducible hernia. So assistant is helping and he is pushing the scrotum and trying to reduce the content by the hand from outside, and inside you will try to pull all the content slowly without traumatizing the any of the big vessel. So now you can see that major content is taken out, and once the traction will reduce, then most of the content automatically will come out. The major part of the strangulation has to be removed first. And now we can see this indirect inguinal hernia is completely visible, and then we will start doing now the dissection. So here incision is given above, and we will start doing the lateral mobilization. So incision was given from the anterior superior iliac spine up to the medial umbilical ligament, and this is the preperitoneal pocket will enlarge, and we will do the lateral dissection, and this preperitoneal space will be opened. So this is TAP, that is transabdominal preperitoneal hernia surgery. So our aim is to open the preperitoneum and make a pocket all around 6 centimeter from the defect, and then we will put the mesh, and then we will close the defect. So, we can see now slowly the pocket is enlarging, and this is the preperitoneal separation of the triangle of pain. And now this is the medial dissection, and at this level you will get the inferior epigastric vessel, so you have to be little careful. Here we are not using seizures. This needle holder base has a seizure, that is mega needle holder with the seizures. So, this preperitoneal initial incision we have given with the simple laparoscopic seizures, and now we have not used seizures either. And if it is somewhere used to cut, then the base of this needle holder has a seizures, so that you can use for cutting. So, entire surgery was blunt dissection, and we can see here the Cooper ligament will be visible. So, after lateral dissection, this is the medial dissection, and then you will go inferomedially to find out the pubic tubercle and the Cooper ligament, that is lighthouse, that is the lacunar ligament. Sometime in the very large hernia, the sac will hide the Cooper ligament. So, you should not try to find it out. If it is required later, you can see. So, this is a giant inguinal hernia. So, sometime the boundary of hernia will go up to the Cooper. So, now we will start the sac dissection, and during the sac dissection it is very important that we should not damage the vas and spermatic vessel, and slowly the sac will be taken out. This is a very large hernia. So, first we should make a posterior window in between the vas and spermatic vessel, and then we should try to separate the sac. So, left hand grasper is slowly pulling the sac anteriorly, and the right hand needle holder is trying to push the vas and spermatic vessel away to make the pocket. So, we can see now the sac is getting separated, and behind the sac here you will see that now the vast difference is started visible, and this is the vas and spermatic vessel. So, that window we have to make in between the vas spermatic vessel and the sac. Without separating the cord structure, if you will directly try to remove the sac, you will have the chances of the injury of this structure. So, the first step is just to make a posterior window in between the sac and the cord structure. We can see this is the vast difference, that was medially, and a spermatic vessel is laterally. Now, we can see again the sac is found, and slowly the separation will start. This is a very giant sac, so you have to keep the patience, and slowly sac will be separated. So, we can see here the major part of the thickened reactive sac which was kept there for long many years is visible, and that got thicked, and assistant is trying to hold the testis so that testis should not come into the abdominal cavity, and we are separating the sac from the transversalis fascia. So, in these cases you have to be very careful that these are the giant sac. So, careful removal of the entire sac is required. However, the sometime if the sac is not coming, you may cut it and leave the remaining sac in the scrotum, but here thankfully we were able to take all the sac out, and it was a complete removal of the sac from the transversalis fascia. So, we can see here this is the major portion of the sac which is separating now from the vas deferens and splenic vessel, and that is completely coming out. Left side of the atraumatic grasper is attached with the bipolar. So, if you have any oozing or any little bleeding, you can catch it by the bipolar. However, right side needle holder has no attachment for any energy sources. So, we are using needle holder as a Maryland to separate all the content of the all the sac wall, and now it is almost done, and the sac is almost separated, and vas and spermatic vessel is away from the sac. These patients are very ignorant and they are not getting their surgery done on proper time, and I don't know for what purpose they are using even alternative medicine for the hernia. Hernia is not a disease, it is a defect, and they should get it performed on the proper time, but they are keeping it, and we can see this huge sac is coming out. But in this type of big sac there is always a little chances of seroma formation. So, anyway, now this was the little lipoma at the level of the neck of the sac, and we are taking the sac away from the vas and spermatic vessel. So, this is almost out, just surrounding some tissue is there, that will be separated, and we should be careful that any active bleeder should not be there to prevent any big hematoma. So, now we can see the dissection part is over. After that, there is a large defect, so we are planning that we should apply some of the few suture just to close the size of the defect. So, here we will use a barbed suture, and with the barbed suture little bit herniorrhaphy will be performed, and we can take a bite over the arc of transversus abdominis, and then we will try to little bit decrease the size of the defect. So, here assistant is dropping the barbed suture, and we will suture the defect. So, again the same needle holder is now doing the job which was previously used for the dissection. Now we are using for suturing, holding the needle, and this is a deep bite should be taken at 2 o'clock position. You should avoid going it below that, otherwise you may injure the iliac vessel, and you should also avoid going at 12 and 11 o'clock position, otherwise you can injure the inferior epigastric vessel. And then with the loop of this barb suture, because starter you do not have to tie, and once you pass the needle through the loop it will get locked and it is closed. So, couple of more bite will be taken lateral over the arc of transversus abdominis, and then assistant is pushing here the transversalis fascia. So, we will fix the transversalis fascia also with the transversalis abdominis. The idea is that it will not create seroma because it will remain inverted inside. So, chances of developing seroma will be minimum, because in the giant hernia chances of seroma increases. And post operatively also we will apply a coconut bandage just like how you do in the hydrocele surgery, and we will give a good scrotal support to prevent the hernia and prevent the sac to create seroma. So, this is the knot is applied. And now again this is laterally at the level of anterior superior, this is on the inguinal ligament area, and now this will be terminated. Because this is a barb suture, so you do not need to tie a knot, and just after pulling it you can cut it, and anyway this should be tension free suture, it should not be under tension. And now we will start the closure of the defect after putting the mesh. So, for the time being we are putting the needle over the medial umbilical ligament, and now here assistant will again push the mesh. Here we are using the simple polypropylene mesh, because as you know in the transabdominal preperitoneal hernia surgery, mesh will be covered by the peritoneum, and healthy peritoneum is the best known adhesive barrier. So, you do not need any expensive composite or dual mesh. So, this is a large size of the mesh which we are using, and that mesh will be first spreaded all around the defect, taking utmost care that center of the defect should be in the center of the mesh. Now the mesh is nicely spreaded all around, and then we will ask our assistant to fire the tacker first over the Cooper ligament and then one over the lateral side. So first is extreme inferomedial and second tacker should be over the extreme superolateral. So only two will be enough to fix the mesh. And here we are using the mesh that is already polypropylene and taking care of that margins of the mesh should not be folded, it should be nicely spreaded. Then only you have a benefit of using the large size mesh. Otherwise, if mesh it get folded, chances of recurrence will be high. So now this is the assistant bringing the tacker and then firing it over the Cooper ligament. If it is not visible, then you should try to hold it and try to give the tactile feedback and then you should fire it over. We should be careful that it should not go to the femoral space or any soft tissue, otherwise hernia also happen, tacker induced hernia. So this is medially it is applied and now one tacker will be extreme superolateral and that's all, it is enough, and after that we will close the peritoneum. So for closure of the peritoneum again we will use the same suture which was used for Herniorrhaphy, just to close the, so this needle is waiting over the medial umbilical ligament and then we will start closing the defect with the continuous suturing. As you know that suturing in the robotic is easy, so it is not difficult and that is why suturing is more preferred, and of course it will be economical as well, and if you will use less number of tacker, patient will have less pain. So that is why suturing should be preferred in the robotic surgery. It is also wise to take few bites over the large sac which you are seeing here, so that sac also will not get retracted, and another advantage that it will reinforce the defect. The sac is peritoneum and peritoneum has a great capacity of remodeling. So, do not worry about, there will be no hydrocele or seroma inside, and this peritoneum will retract automatically because now there is no content coming. So, within few weeks this entire pouch of the sac which you are seeing will obliterate. So, this is the closure of the defect, and we should take care that any portion of the mesh should not be visible while you are closing the defect. So, this was just a simple case of giant right sided indirect inguinal hernia where robotic surgery was performed. So, any buttonhole should be avoided. However, if a small buttonhole is there, then as soon as gas will be taken out, pneumoperitoneum gas, then it will automatically it will close, but we should try to close as much as possible. So, thank you very much for watching this video. Have a nice day.